everyone, and welcome. I am Rachel, Community Manager here at Alloy Women's Health. We are a digital health platform bringing science-backed, evidence-based menopause hormonal solutions direct to your door. Today, I am joined by Alloy's Director of Advocacy and Outreach, also Alloy's prescribing physician, Dr. Kudzai Dombo. This is a follow-up to our last webinar. This hour is meant to respond to the many, many questions received that we didn't get to the first time. So I'm going to start, Dr. Dombo, at the top of the list and just go all the way through. For those of you watching, please know that because Dr. Dombo is not your private physician, she cannot give direct medical advice to certain questions, but she can certainly offer an opinion and answer in broad strokes. Is that fair, Dr. Dombo, to say? Yeah. Okay. Okay, so let's begin. I saw a recent article about how night sweats can be harmful and lead to other serious conditions. Can you explain?
Absolutely. Well, thank you, Rachel, for the introduction. So night sweats, sometimes we think that night sweats are, just really bothersome symptoms, but the degree of severity of the night sweats can actually impact, they've shown a direct link between cardiovascular disease as well as, the impact on your brain. So we sometimes think that, night sweats, let me just, muscle through. But the truth of the matter is that the impact on your heart, direct impact on your heart and on your brain are very, very well studied. So it's important to know that they may be a bothersome symptom, but I think, when you look at the long-term effect on your heart and your brain, you really want to be aware that this is something that's more than just a bothersome symptom. It has impact elsewhere.
Thank you. How can a woman know when she is in perimenopause, early or middle? Only recently did I connect or accept that I am in perimenopause. I would like to know if I am near the start or closer to moving into menopause.
So we don't have a clear idea of the exact timing for each and every individual woman. But what we do know is that, again, perimenopause is the 10 years that approximately 10 years before menopause. And we know that the definition, as we said, of menopause is 12 months without your period. So what you tend to notice during perimenopause is either, number one, a change in your menstrual cycles. So you may notice a shortening of the interval between the time of bleeding. You may notice that your periods become extremely heavy, or you may notice that they are prolonged, like longer than 8 days. We typically say the normal duration of a menstrual period is about 5 to 7 days. So when you start noticing that your periods are either longer, heavier, or the interval between a period starts to change, that is one indication. But then, you know what? Some women don't even have any changes in their periods. They just start to notice symptoms, the symptoms that are that you would typically see with menopause. So it's an either or a combination of both, but there's no distinct like, okay, so early perimenopause, late perimenopause. I think you're really looking at just your body and what are some of the changes that you may see, and then also, the severity of symptoms.
Thank you for that. I think often I say this in support groups a lot, that it's so helpful to somehow keep record of your symptoms, of when you get your period. It just sort of helps because we forget. And if you're perimenopausal for years, you're not necessarily going to remember that your symptoms started one way 5 or 6 years ago, and now you're not exhibiting those symptoms at all, but something else is showing up. But it's that many years later, you must be closer to menopause, but you still may have a way to go.
Yeah, 100%.
Thank you, Dr. Dombo.
Yep.
Next question. Are supplements like evening primrose or estrogen good? I started taking and it seemed to make my hot flashes worse. I assume it's because it was changing my hormone levels again. Should I push through?
Great question. So I know that, whether you choose to take supplements, whether you choose to start with, hormone therapy for symptomatic relief, I mean, everybody is at a different place. I think when I think about supplements, and I can actually relate to my own journey, I knew that some of the really bothersome symptoms that I had were like the sleep disturbances. So I started looking at, okay, what will help with sleep? Magnesium glycinate. I started to look at, gosh, what is that? Melatonin. But at the end of the day, I knew that when it came to dealing with the root cause, right? Like the either fluctuations of hormone levels, it wasn't going to address the root cause,
Right.
right? And so,
And the root
everybody's
cause being
either fluctuating,
hormones. Okay.
yeah, your hormones.
Mhm,
Like
mhm.
the underlying premise of perimenopause and menopause is that your hormones are changing. You're either having fluctuations, wild fluctuations of hormone levels in perimenopause, and then a gradual decline in your estradiol levels. So again, supplements can help for those who either cannot take hormones or choose not to take hormones. But I think it's important to realize that, the root cause, which is, the estradiol levels, and then the long-term benefits that, replacement of estradiol and progesterone, it's not going to benefit you in the long term when it comes to cardiovascular disease, when it comes to brain health, when it comes to all, bone health. Those kinds of things you're not going to necessarily see the benefit from taking supplements. They may
Yeah.
provide temporary relief, but not necessarily the long-term relief.
I think of, and it took me a long time to get there to think about hormones this way, estrogen, progesterone specifically, but I think of them now as sort of a first line of defense. I
Mhm.
too take magnesium and I take a B vitamin.
Yeah,
Um, but I think of those really as supplementing, sort of where there may be gaps, whereas like
yeah,
hormones, I feel like it's bigger than a gap. It's just like a
yes,
depletion, really. And
right.
so I need something else. I don't know if that makes sense or is
Yeah.
helpful, but
No, it's, I think you're 100% right. It's the difference between looking at, again, just as I said, the root cause or
yeah.
your like, because I think there's a role for having supplements and hormones like working
Sure.
together. Because I'll share from my own personal, even though I do use progesterone at bedtime to help with sleep, I still notice that that sometimes is not enough, right? So that I use, in addition, I use magnesium glycinate, and the combination is helpful because I
Sure.
know that, you know, if I am magnesium deficient, for example, and I haven't tested my blood levels, but that magnesium is a supplement to
Right,
what I may not be getting through my diet.
right,
So I
right.
look at it from that perspective, and I think that's just what you were mentioning when you just shared that we're supplementing what our bodies may not necessarily have enough of.
Right, great. Thank you. Um, This is really about, this next question is about how do you advocate for yourself? This person asks, how do you get help from physicians who are not versed in perimenopause and menopause symptoms, especially when you are a woman of color? Going to
Mhm.
gynecologists, dermatologists, allergists, and primary care. They want to prescribe medication, excuse me, and you ask to talk about coming up with a treatment plan. It becomes a battle to advocate for yourself. Can you speak?
Yeah.
That's a big, important
Yeah,
issue.
it's definitely the truth of the matter is it's not easy, and I also can share from, again, my own perspective that, like, I've had to educate some of the specialists or some of the doctors that I've seen. Um, but I also know that I chose to see a very specific physician who was in midlife who could actually identify certain things that were related to my hormones. And I'm not saying that that is going to be the truth for everyone, right? I just think that it's important that, again, you do research. There are places where you can find menopause trained physicians, like the Menopause Society has a database of menopause trained clinicians. There are places like Alloy where we are really trying to make sure that our clinicians are aware of the cultural sensitivity and the cultural competence of caring for women who may not necessarily be of, one type of, demographic. We're really trying to look at, for all women, women of different cultures and sensitivities and backgrounds. How do we make sure that we're not just looking at, okay, this is the person in front of me, but we're looking at all this, the social constructs as well that this person's comes with. So I think it's important to start investigating and finding clinicians that have done the extra work to get additional training in perimenopause and menopause. And it's important that you find someone who wants to be able to look at the whole picture. And okay, that's not coming across correctly.
No, no, no.
Um,
I got you. I got you. I'm also thinking, you follow up with this, so let me know what you think. I'm thinking about when you go to a doctor, if you can, when you schedule that appointment, inquire about the physician, inquire if they have any sort of background in menopause care, but also importantly, if you can, schedule a longer appointment so that there is time for all of the unpacking, all of the questions, maybe not all, but several of the questions that you have to
mhm.
come out, to be shared, to be answered. I don't know if that is helpful at
Yeah.
all.
So I think it would be helpful to make sure that you are not, or make sure that if you know that you're going in for your annual, you're not lumping it in with all these questions you have for your, that you have for the clinician about perimenopause and menopause. So I
Okay.
100% agree that it's important to call beforehand, even ask like how many patients, what is the number of patients that you take care of that are perimenopausal and menopausal? Because I think it's almost like surgery, right? If I know that I'm going to have a fibroid taken out, I want to go to a doctor who does it frequently. I don't want
Yeah,
to go to a
good
doctor
point.
who does it like once a year, twice a year,
Mhm,
but somebody who does it once a week,
mhm.
because that doctor is versed in all the complications, all the nuances, and how to figure out the best way to do that surgery. So I think it's the same way, with perimenopause and menopause, in that you want to, I mean, if you call, you can even ask the front desk, do you know the percentage of patients that this clinician takes care of that are within this this with this particular with perimenopause and menopause. And then also you can make sure that you can schedule an appointment dedicated to just that, right? So you're
Great.
not
Yeah.
combining it with your annual exam, because the doctor is going to be like, okay, well, I'm focused on, your screenings and your annual, but you also have questions about, perimenopause and menopause. It might be better to make separate visits for that.
Yeah. And I think to your point initially in response to this question, that is why a platform like ours is so helpful and so uh instrumental in kind of filling that space that may be lacking. You still need to go into your doctor's
Yeah.
appointment for your labs and your pap and your breast exam and all of that, but we're here to meet patients where they are, who they are, with all of the sensitivity and training pertinent to this time of life, if that makes
Yep.
sense. Yeah,
100%.
thank you.
Uh,
Um, I am soon to be 59. I was on hormone replacement, but stopped because it could cause hair loss. She indicates testosterone cream. I
okay.
have had serious hair loss and want to keep my hair, but not sure what to do. I've seen several doctors, but I've not been provided clear direction. I have no sex drive since I stopped the testosterone cream.
Got it. So there are a lot of different questions I have, because it's like, okay, I'm not sure how long you were on it, like what dose you were on it, because I think testosterone cream is definitely one of the, you know, hormone replacements that is approved for what we call hypoactive sexual dysfunction disorder. And so being on testosterone therapy has definitely been shown in even research studies to improve sex drive or libido. And so the downside is that if testosterone levels get too high, it can contribute to hair loss. So being able to dance around with a dose that's appropriate, but not too high that's going to, lead to side effects it's a very fine-tuned balance. So that would just be my first question would be like, how long and how high of a dosage you were on, because, the delicate dance is coming up with a dosage that may provide you with the benefits without the side effects.
Sure.
The second thing I was going to say is with hair loss can occur during, when our hormones change. We do see it postpartum, like after delivery, during these major shifts in hormones that can tend to precipitate hair loss. There are different things that can tend to help with that. So even if you do start with, like, let's say an estradiol and a progesterone, it still takes at least 3 to 6 months to notice a change, and it can be very distressing to experience hair loss.
Yeah.
So one of the things that I typically if you're at a point where it's extremely distressing, very low dose oral minoxidil has been shown to help increase blood supply, to the, hair follicles and promote hair growth. So that is one possible solution. But again, a lot of times it's combined with either biotin or vitamin D as a supplement to really help promote its benefits. It's again another thing where a hair cycle can be anywhere from 3 to 6 months. So being able to see the benefits of that take time.
Yeah, I can say anecdotally, I've been using our oral minoxidil and it's been close to 6 months now. And I'm starting to see probably about 4.5 months. I
Yeah.
noticed much less shedding and like all of this is starting to come back. For what
Nice.
it's worth, I know. For what
Oh,
it's worth, take a look. It makes a
okay.
difference. Not
Yeah.
you, but any women out there, any woman out there struggling with hair loss. It's a big, impactful thing to deal with. It's so common, as Dr. Dombo said, in perimenopause. But there are solutions. So
Yeah.
thank you. Um, can women who are at increased risk for stroke use HRT or MHT?
So the question then becomes, what we do know is that if you have had a stroke, that is a contraindication for hormone therapy. However, increased risk of stroke is going to really be taking a look at what are those increased risks of stroke? Is that family history of stroke? And if it is a family history of stroke, then we can actually look at using transdermal, estradiol, because one of the benefits of a transdermal form of estradiol versus oral is that oral has to be, absorbed into your GI system and it's processed first pass by the liver, and that activates clotting factors. So when you actually use a transdermal form where that is absorbed through your skin and enters your bloodstream directly, you eliminate some of those risks. So it really depends on what the specific increased risk of stroke is. Again, is it simply a family history, or have you had something in your own personal medical history that determines that you're at increased risk of stroke? It's really, again, looking at that, and then also shared decision making. How
Right.
bad are your symptoms? And, you know, do the benefits outweigh the risks?
And Dr. Dombo, just to hover there for a minute, if you yourself have had a blood clot and
Hmm.
maybe you had it on a plane or you had it
Hmm.
as a result of a broken bone,
Yeah.
that exempt you. In what case would you be completely exempt from?
Yeah. So again, I hate to use the words complete because, I think it can be a very nuanced discussion, but a lot of times if you've had a provoked clot where, oh my gosh, I had a blood clot after a very long flight, or I had surgery and I had a blood clot after that, or I had a skiing accident and then I had a blood clot. Those are what we called provoked blood clots. And a lot of times when you look at somebody who's had a provoked blood clot, using a transdermal estradiol tends to be a lot safer than somebody who I was on birth control pills and I had a blood clot. That
Okay.
is something that's been induced by hormones, and that tends to be I look at that completely differently than somebody who's had
But
a
still a
spot.
nuanced discussion.
Exactly. It's still a nuanced discussion.
Thank you. I'm on HRT, estradiol patch, and have an IUD. I've been on the IUD since 2024 and continue with spotting. Is it normal to continue spotting daily? Wondering when the spotting will stop.
Okay. So it's very normal to have spotting with an IUD. So just so that everybody's aware, an IUD is was this a progesterone IUD? Did
She
she say
didn't say.
progesterone? Okay. So there are two different types of IUDs. You have a copper IUD, which again just creates the copper in the IUD creates an environment that's hostile to sperm. So that serves as a contraceptive. But then you also can have a hormonal IUD. And the hormonal IUD, progesterone, it really thins out the lining of your, of your endometrium, which is the uterine lining, and can help not only with contraception, but it can also help with to reduce heavy periods. So depending on what kind of IUD you have, let's say it's a hormonal IUD and you're having spotting, I'm not as worried or concerned because the progesterone in the IUD is already thinning out that lining. And I think it's more of a inconvenience that you're experiencing the spotting. Because normally you would have a period, but if you're spotting instead of having a period, it's annoying, but it's still there.
Okay.
So, and so again, what was the question?
She's asking, is it normal to continue spotting daily, but she doesn't indicate what kind of an IUD she has, and she's wondering
Mhm.
when the spotting will stop. She's also on an estradiol patch.
Right. So again, it just depends on how long. Like the first few months after having, like the first at least 3 months, I always tell all my patients, if you're going to have irregular bleeding, on an IUD. And it can take some time for your body to acclimate to the hormone that's in there. And some women have absolutely no periods. I'm sorry, excuse me. I have a bit of a cold, but some women have no bleeding at all, once their body acclimates, whereas some people still have periods and those periods can be light, whereas some people will have spotting every now and then when they would expect to have a period. So it's very hard to kind of answer when the spotting may change for her, but it's one of those things that would be important just to discuss with your doctor based on, again, the length of time. And if it's annoying, if it's bothersome, that would be another conversation to have with your own personal, doctor about that.
Dr. Dombo, just on the issue of bleeding, for a woman who's clear that she is in perimenopause, and we understand, again, I guess I'm just sort of getting to the murkiness of this and when women should be sort of more, um, you know, purposeful about connecting with their doctor.
Yeah.
So you're in perimenopause, you're going through your 40s, you're still getting a period, your period is starting to wane, the time in between periods is increasing, and you're now menopausal, you've had your 12 months without a period, so you are
Yeah.
menopausal, and 6 months later, you bleed.
Hmm.
Is that normal? Is that to be expected? Is that worrisome?
Right. So any bleeding after you've gone 12 months without a cycle definitely needs to be investigated. So if, again, you've been through the 12 months, no period, you start to have bleeding, it's always recommended to just go to an OBGYN who can either evaluate that lining, with either a transvaginal ultrasound, or an endometrial biopsy, because worst case scenario, we always want to make sure that there's no like underlying, like either precancer or cancer that could be contributing to that bleeding.
Okay, thank you for
Yeah.
that. Um, I'm 57 years old and I have been in menopause. I have rheumatoid arthritis and osteoporosis. I'm now scheduled for a full hysterectomy and was wondering how soon I should start HRT.
Again, it depends. I mean, I would say immediately. You're already 57, right? And it has been shown that women who have had hysterectomy, well, first of all, let me go back. So you're 57, so you're already postmenopausal, more than likely. I'm making that assumption. But I could be wrong, but that would be something that I would want to make sure of is that are you still having periods? Are you not having periods? Because I have seen women at 56 who are still having periods. So I don't want to make any assumptions there. But if you are still having periods, and that's part of the reason why you're having the hysterectomy, um, I would recommend discussing starting immediately because the benefits of starting it before age 60 or within 10 years of your last menstrual period, that's the optimal timing to start hormone therapy. And the other question I do have is I don't know if you're having any symptoms um, and if the plan is for them to take your ovaries out. So
Right.
if they're going to take your ovaries out, again, so it's a very it's I wish I could answer this question with more information because yeah, I would want to know are they planning on taking your ovaries or are they going to keep your ovaries in? Were you having periods? But if I was in your situation, I personally would elect to choose hormone therapy.
Great, thank you.
Yep.
This is another supplement related question. I'm 41 and just started my journey into perimenopause 2 years ago. I've been able to stave off symptoms with supplements. I know there will be a point where I max this out. Is this a sustainable approach, or would you suggest going the hormone therapy route?
Great question. Because that's what I did.
Me
And I
too.
think Rachel, I think you did that as well.
Yeah.
You start with supplements because you obviously want to try, everything to try to help. And I think when I started hormone therapy, I was like, I wish I had just done this sooner. What was I thinking? And for two reasons. One, because I had such, significant, symptomatic relief. And the supplements were helpful, but I found that after a while, like, the benefit, I lost the effects of the benefits. That can still happen with hormone therapy where, the dose needs to be tweaked. But I think with supplements, you're looking at, you know, ways that you're supplementing what your body may be deficient of naturally, whereas hormone therapy is addressing the root cause. And it has such great long-term benefits when it comes to protecting your heart from heart disease. And as Black women, we already know that we're at higher risk for hypertension, diabetes, obesity, and higher risk for heart disease, 30% higher than Caucasian women. So knowing that, I would want to do what I can, not only to help my symptoms, but also to reduce the long-term, you know, complications that can occur.
If I can just stick here for a moment as well. This question is so interesting to me too, because she indicates she's 41. She started perimenopause as best she can identify it 2 years ago. This sounds very similar to me, by
Mm-hmm.
the way. And she's been able to stave off symptoms with supplements. But I
Mm-hmm.
think a lot about what you have said, what other physicians have said here, which is sort of what your symptoms are and how intrusive they are to your life. And,
Mm-hmm.
I can't make sweeping generalizations, but we know that perimenopause is harder, starts earlier, is more
Yeah,
impactful to, is more severe. There are more symptoms that Black
yeah,
women experience.
yeah.
So it makes me think about this issue of age and then this issue of symptoms, because also for a 41-year-old, if you had told me at 41, when I was definitely perimenopausal, you can start taking HRT, which, by the way, my gynecologist did offer to me at the time.
Yeah,
And I said, no, no, no. I was just coming off of the birth control pill.
yeah.
So to hear, we're still sort of making associations, I think, about age
Mhm.
and MHT. When
Yeah,
really, and correct me if I'm wrong, I guess I'm laboring to get to this question, but really,
yeah.
is there an age, or like, what are you really looking at when you determine it's time to start MHT? Is it the symptoms? Is it the age? Is it the combination of the two?
I think it's very individual specific. Just as you
Okay.
said, you weren't ready to start,
Nope.
right? And so I think I don't ever say that there's an exact age at which you should start at least, I know that before age 60,
Right.
within the last 10 years of your last menstrual period are beneficial. But I think I leave it to it's to each individual. If you feel like you're on the birth control pill already and you are having these symptoms that are bothersome and you feel like, I'm having hot flashes, night sweats, and I'm on the pill, and that's not helping relieve the symptoms, and they're impacting my quality of life, then let's have a conversation as to what we can do to make you feel better. Because I think it really comes down to the point at which it's impacting the quality of your life. That we
Great.
need to really, and only each person can say that, each
Yeah.
individual can say that.
Yeah.
So
Thank you.
I really leave it to the patient.
There's another thing you brought up when you answered this question. You talked about the tweaking of MHT. And again, especially because this conversation is speaking to and on behalf of Black women who may be suffering more with symptoms. And again, many women think where I start on MHT is where I land. So can you let us know a little bit about tweaking and when to know and how to know and what you might look at first and what you might adjust versus not for a patient?
And you're referring specifically to MHT?
I am.
Yeah.
Mhm.
I mean, I think again, I always tell patients that you're the one who has to tell me how you're doing, right? On a particular dose. So the goal for me is 70 to 80% improvement in symptoms on any dose. So let's say we start you on a 0.05 milligram patch, progesterone 100 milligrams, and you're doing fantastic. And, we're 6 months in, you've been feeling great for 6 months. And then all of a sudden you start to notice that you're all of a sudden experiencing like hot flashes again, or you're experiencing some mood symptoms that previously were improved by the dose that you were on, and you're noticing a return in your symptoms, then we can talk about tweaking your dose. Or, it can be like, you know what, I'm doing really well with the hot flashes. It's just the sleep quality that has just started to creep in. And we can talk about tweaking your progesterone dose. So it really depends on each
Okay.
individual. But I do always say that the way that you can tell me whether or not your dose needs to be tweaked is whether or not we're at that 80% improvement.
Okay.
Because if we start to aim for 100%, like for everything to be gone, we're going to run into, side effects, increasing doses to a point where the side effects may start to manifest. So that's how
Super
I go
cool.
about it.
Can women take HRT while breastfeeding? If you're an older mother in your mid 40s, is it harmful to newborns to be on HRT while breastfeeding?
Okay, great question. So during breastfeeding, what tends to happen in order for you to produce breast milk is that prolactin, which is a hormone produced by your brain, increases, and that's what allows for breast milk production. But with the increase of prolactin, you have a decrease of estradiol, right? So what tends to happen is in order for you to continue to produce, breast milk, we want to keep the prolactin high and prevent estradiol from shutting that down. So when you're breastfeeding, we don't recommend any kind of estradiol or estrogen, even estrogen, any estrogen containing birth control pills. So when it comes to systemic hormone therapy, we don't recommend it. But what can tend to happen during that time is the lower estradiol levels can cause vaginal dryness and you can have painful intercourse. So using like vaginal estrogen, which is local, and that is one thing that, we recommend is, if you find that you have painful intercourse, you find that you have like vaginal symptoms like dryness or itching, vaginal estrogen is what we recommend during breastfeeding. But systemic hormone therapy can interfere with your ability to produce breast milk. So we don't recommend systemic hormone therapy during breastfeeding.
Great, thank you.
Yep.
Um, I had breast cancer, this person asks, 11 years ago that was hormone negative, yet every doctor has said that I cannot have hormone therapy simply because I had breast cancer. Is hormone therapy safe if your cancer was not hormone sensitive?
Great question.
Yeah.
So again, I think this is where it comes to shared decision making because there are two things that I hear. It was hormone receptor negative, and it's been at least 11 years.
Mm.
So it's very nuanced in the approach, and it takes a shared decision making to determine whether or not this is something that you you are okay with, because there are certain candidates who have breast cancer who may not, the risks may outweigh the benefits, but there are others who where the benefits may outweigh,
Mm.
any risks. And again, it's a very individual personal choice. And for example, I have a patient who she's she was ER negative, PR negative, and was diagnosed, over 15 years ago. And basically, she elected to go on hormone therapy. But again, it was shared decision making. It was a lot of going over, what are the risks, and just having discussions with her oncologists. So it's a team approach. But again, it's really shared decision making because some patients are better candidates than others.
Great, thank you.
Yeah.
And finally, and I know this is a pretty big question, so allot as much time to it as you can. But this final question is: please discuss endometriosis and HRT and
Mhm.
progesterone specifically.
Yeah. So endometriosis is a condition where you may have these implants of uh, the lining, of the inside lining of the uterus in the actual abdominal or peritoneal cavity, or, on the ovaries, different places. So these part of the lining of the endometrium is in a location that is not where it technically is supposed to be. And that can cause a lot of pain, when you have periods. And one of the things that, we say is we always recommend being, like the birth control can help suppress, the amount of hormone that your ovaries produce to reduce the discomfort and the pain when you have endometriosis. So HRT is not a contraindication when you have endometriosis, but a lot of times what we do want to make sure of is that the amount of progesterone that you are taking in relation to the estradiol is enough to prevent any kind of reactivation of any endometriotic implants. So it's very simple. It's really the goal is not to cause any activation of your endometriotic implants. And we can do that with, a ratio of estradiol to progesterone that may be specific to, you as an individual, but will not reactivate any of the implants.
And Dr. Dombo, in this individual's case, how is that monitored? Does this person come in for testing, or is it really, if you're experiencing pain, you're still getting a period, then
So that's what we look out for.
okay.
We actually say, like, just let us know, because if you start to notice that you're having any pain or discomfort, then we need to really adjust things to make sure that, the amount of progesterone is, uh, high enough to combat, or to make sure that the estradiol is not activating any endometriotic implants.
Thank you, Dr. Dombo. Is there anything else you want to sort of leave us with after this conversation, which was, full of questions from a variety of women who joined us for that webinar? I'm looking so forward to more conversations with you and answering
Yeah.
women's questions. But at this moment, is there anything that
I mean, I think it's just important that as Black women, we're looking at our health, and not leaving it to others, right? To determine what's best for us. Because I think, again, as we enter this menopause transition, we have a higher disease burden, right? Of diabetes, hypertension, higher cholesterol. So it's important, in your 30s and your 40s to start really making sure that you're getting screened,
Mm,
for all of that, and that our numbers are like optimal ideal, like our blood pressure is well controlled. When we look at our cholesterol, that's absolutely well controlled. And then we're doing all the other things, like what are we doing
right?
for stress management? Do we have a specific, technique, that we know that, okay, this is what I'm doing to manage my stress? Because again, it has already been shown that we endure and we go through way more stress that leads to weathering, that leads to a higher allostatic load. So how can we manage our stress? How can we make sure that, I am, mind, body, soul, like it's all looked at as something that's important, and not, we don't compromise on that.
Mm.
So I think it's just important to really make sure that we're there so that we can take care of not only ourselves, but, all the other people. Because if we're not taking care of ourselves, everybody else will suffer as well.
Thank you for that. I just want to quickly add that I loved hearing throughout this hour your repeatedly amplifying personal choice, right? That menopause care is nuanced care, but your voice, your choice matters overall.
Mm-hmm.
And shared decision making, making decisions for yourself ultimately comes with an understanding of risks, but it also comes with an understanding of facts and
Mm-hmm.
really sort of knowing, um, being educated makes all the difference. And
Yeah.
you are going to be able to make the best decisions for your health at any given moment if given the resources and the information upfront.
Yeah.
And I think that's ultimately what we're so excited about here in
Mm-hmm.
this work that we're doing, that you're leading the charge of, is educating women, creating space for women to come together, be heard, be supported, be in community with one another, and
Yeah.
then of course receive information about what is available to them so that
Yeah.
they truly can get on with a healthy second season of life.
Yeah.
Um, in many cases, hopefully reaching out to younger women so that they have just a healthy, vibrant 2/3 remainder
Yeah.
of life. And I thank you for your work and efforts here in this.
Thank you, Rachel. Much appreciated.
Thanks, everyone. And we'll be back with much, much more. You'll be seeing us as the year goes on. Thank you.
All right.
Bye.
Bye.